Quick notes on parafunction. Parafunction includes bruxing, clenching, gnashing, grinding, bracing, and all other activities that are not included in function. It can be daytime or nighttime, but the etiologies of daytime parafunction are different from nighttime parafunction. Daytime parafunction is mostly related to drugs or habits or a nervous behavior. Nighttime parafunction, however, is a central nervous system mediated activity primarily. Peripheral tooth contacts have no influence on nocturnal parafunction, so a high restoration or a high crown given by you will not cause the patient to brux. Nocturnal parafunction can be primary when it is a normal central nervous system activity which is part of arousal phenomena, or it can be secondary to four causes. It can be secondary to medical conditions like obstructive sleep apnea, sleep disorders, neurologic disorders, and psychiatric disorders. It can be secondary to stress. It can be secondary to alcohol intake, drug abuse, caffeine abuse. It can be secondary to certain medications that increase primary bruxism. Do you need to treat bruxism? No, you don't. If the patient has no problem, no muscle pain complaint, no joint pain complaint, no other side effects associated with masticatory apparatus. An important question: can you treat bruxism? No, you can only manage bruxism transiently. But surely you can both treat the effects of bruxism on the teeth, masticatory apparatus, and the joints, and manage the effects of bruxism on these three entities of the masticatory apparatus. You only need to manage bruxism when the patient has its side effects on the masticatory apparatus, like masticatory muscle pain, or attrition, abrasion, abfraction of dentition, or degeneration of the temporomandibular joint, or other headache disorders. Is the relationship between pain and parafunction direct? Which means patients who parafunction have pain necessarily? No, not at all. Patients who parafunction on a regular basis are one of the most adapted patients. They rarely complain of pain. It is only a transient increase in parafunction which can be secondary to certain things that the patient starts having symptoms associated with muscles and the joints. What is the best method to control parafunction even transiently? The best method to control secondary parafunction is by, of course, controlling the cause of parafunction and by instituting nighttime, flat plane, hard, full coverage occlusal appliances. They work better than anterior deprogrammers too. Soft vinyl night guards or soft occlusal appliances have to be totally avoided because they in fact increase parafunction. Do nighttime hard, full coverage, flat plane appliances control parafunction permanently? No. They reduce parafunction only transiently, and it bounces back within 6 weeks if the appliance is unchanged. Behavioral modalities like biofeedback, TENS therapy, hypnosis, psychoanalysis, sleep hygiene, meditation do not work predictably on parafunction. Does Botox treat or control parafunction? Absolutely not. Botox causes motor paralysis of the muscle that is injected, and parafunction is a central nervous system activity. So, Botox has no effect in controlling parafunction. It only controls the intensity of contraction of the effector muscle. It can reduce the intensity of contraction in the effector muscle, and it can reduce pain in an hyperactive muscle to a certain degree, but it's not a definitive treatment. Are there some drugs that control parafunction? Yes, definitely. There are some drugs that have considerable effects on parafunction, but they are associated with considerable side effects and should not be administered just for the sake of controlling parafunction in asymptomatic patients, and definitely also not in symptomatic patients, because we have safer conservative alternatives in the form of nighttime appliances.